Hello, my name is Amit Pawa. This is a modified version of the talk I gave at the ESRA 2024 Annual Congress in Regional Anaesthesia that was held in Prague in the Czech Republic. This talk will focus on the non-technical aspects of how to deliver awake major breast surgery, and during the Congress this was followed by a talk by Dr Teresa Parras where she talked about the techniques in a bit more detail and some of those other practical aspects. In terms of disclosures for this lecture, I do have a podcast which you may or may not know about called Block It Like It's Hot. Obviously, you're watching this on the YouTube channel, and from my point of view, I've had a long-standing good friendship with Dr. Teresa Parras, and in the past, we've even done pro-con debates on what technique is better for breast surgery, but this is very much a kind of all-inclusive lecture, so no pro-con debates here. The resources I'd like to direct you to are this particular podcast episode of Block It Like It's Hot. I've happened to show the Apple and the Spotify versions here. And in this episode, we talked about regional anaesthesia for breast surgery. And at the end of the episode, I discussed with Jeff Gadsden my take on the best way of performing awake breast surgery. More importantly, there's this article that I wrote together with Professor Duncan Hamilton, and here, this is published in BJA Education. This QR code will take you to that article. All of the content from this presentation, or at least a large majority of it, came from this publication. So to start off with, I'm going to talk about 4 truths of awake breast surgery. The first is that actually most patients can have a general anaesthetic, and the real skill is knowing when you can avoid one and when to avoid one if at all possible. The second truth is that awake breast surgery is not suitable for all patients, and it may be that some patients have a needle phobia, don't like the idea of being awake, and you can try and coax them through a whole host of different strategies, but actually there may be some patients for which this technique is not suitable. Perhaps most importantly, it's not all about the blocks, and preparation for awake breast surgery is really key. There have been situations where you might do the most perfect regional anaesthetic technique, but if you haven't prepared the patient for what's about to follow, they may find it challenging and difficult to deal with. That brings us along to our last part here. The last truth is that it's really important to have a plan B or a backup plan. And that plan B may be that if the regional anaesthesia technique doesn't work, we don't proceed any further and we come back at another time, or it may be conversion to general anaesthetic. Whatever it is, you need to have thought about it in advance and therefore have a plan and know you can institute it if required. So over the rest of the presentation, I'm going to cover why we might consider performing awake breast surgery. We're going to go through the stages of patient preparation, and then we're going to talk about the team preparation, including what the anaesthetist needs to bear in mind. And then finally, I'm going to give you some tips and tricks and things that I've now considered essential when assessing how effectively one can deliver this technique. So, why awake breast surgery? Well, we've highlighted in the article a whole host of potential indications, and actually I have in the past anaesthetised patients that have fitted into all of those categories. The vast majority of patients may just be considered high risk for general anaesthesia, generally because of cardiorespiratory disease. I have had situations in the past where we have patients who have had a difficult airway, either because of a free flap reconstruction or because of radiotherapy to the neck, and it may be that you want to consider a regional anaesthetic technique to avoid any airway manipulation. Can be situations such as frailty, and that's sometimes difficult to define, but somebody maybe just doesn't have the reserves you don't think to go through a general anaesthetic. Or there may be physiological circumstances such as pregnancy where avoidance of general anaesthetic may be considered to be beneficial. We do have some patients who genuinely have an anxiety or a fear of general anaesthetic, and in fact the first case of awake breast surgery I did was in such a patient. Well, there may be a cohort of patients who are very keen to avoid opioids, or in whom you want to minimize the level of opioids or degree of opioids given, and that may be an indication for awake major breast surgery. So let's start off with patient preparation. It's really key that you identify potential patients for this technique early, and in an ideal world you would meet these patients at the pre-assessment phase, so that you could have a chance to meet them, tell them what's involved with the technique, and more importantly, so you could assess their suitability. Are there any obvious contraindications or concerns about them having this technique? Do they have a lot of metalwork in the back for previous surgery? Are they on direct oral anticoagulant medications? So it's important to identify whether this is somebody who may be able to go through this technique, or more importantly, are there reasons why it's not suitable? The next thing is really important to do at the early stage is to describe the technique in detail. Make sure they understand, they know what the risks are, and give them that information either in a written form or, if possible, via a video format. I'm going to go through some of that preparation in a bit more detail now. So I like to think about it in terms of breaking it down into the preoperative phase and the intraoperative phase in terms of telling them what to expect. So, of course, many people think they're just going to have a local anaesthetic technique, and they don't understand that it's important that we establish intravenous access and put them on full monitoring so you can pick up any potential complications or adverse effects of your regional technique. And I talk them through the spectrum of being truly awake, in which case there may be some patients where you really don't want to use any pharmacological agents, versus slightly deeper sedation or the different levels of sedation. And then talk about other non-pharmacological ways of keeping them calm and relaxed with audiovisual distraction. And that could be as simple as talking to the anaesthetist, or it could be using video or music or even virtual reality. And then talk about the oxygenation techniques. There may be some patients in whom, depending upon their indication for awake breast surgery, you don't need to give supplemental oxygen technique, but versus those in whom you need to do something a little bit more invasive. And then I go through the process of talking about how I insert the blocks, what position I put the patient into, and more importantly, once the blocks have been inserted, then we wait a period of time and check that they are actually effective. And it's really important that patients have that confidence and understand those phases. When it comes to the intraoperative phase, I think it's really important that patients realise that actually the drape's going to be very close to their head. And I do everything I can to use drip stands to hold the drapes up and out of the way, but I do explain to them that it can feel a little bit claustrophobic when we're doing that, and that we will take care when positioning them. Sometimes patients have back pain or hip or shoulder pain, and we need to think about the things that we need to do to encourage or to allow them to lay comfortably during the surgery. So we make sure we discuss all of those aspects with patients. And also, again, reiterate the fact that we will test the block effectiveness before surgery. And if something's not quite right, we will act upon it. And I also let them know that they won't be alone, because many patients feel that we'll do our technique and as anaesthetists we then step away and leave them by themselves to go through this ordeal. We won't. We will be there the whole time. It's important that they know that. And lastly, I talk about what happens if things don't go according to plan. What happens if they feel some discomfort? What happens if they change their mind? I let them know that we have options available to deal with that. If you provided your information to the patient effectively, they should now be motivated to go ahead. They should be informed, reassured and trusting. And remember, a lot of these patients will have been told from somewhere else that they can't have their surgery. So if you can then provide them with that format and say, look, actually we can do the surgery, but these are the things that are going to take place. If they trust you, it makes a big difference. Now, what about the anaesthetist? How do we prepare the anaesthetist? Well, it goes without saying that our anaesthetist needs to have the necessary regional anaesthesia experience in order to perform successful awake major breast surgery. They need to know how to perform these techniques. This shouldn't be the first time they're siting a paravertebral or some other block. Regional anaesthetists tend to, in a self-selecting kind of way, be good at communication. So it's really important that the anaesthetist is able to possess good communication skills to frame the conversation in a positive light and make sure the patient feels calm and relaxed throughout. Because if the anaesthetist comes across as confident and reassuring, the patient will feel calm and relaxed. We also, as anaesthetists, need to understand the location of the surgery and the type of surgery and decide whether we need to modify our technique depending upon the type of surgery that the patient's having, as opposed to just having a blank template that or a template that we just apply irrespective of what's going on. And then really importantly, we need to have decided what dose of local anaesthetic we're going to use in advance and possibly keep some in reserve for a rescue strategy to give to the surgeons, because what we don't want to be doing is just continuously be topping up local anaesthetic, and before you realise it, you've overcome or you've gone over and exceeded that maximum dose. Once we've got the anaesthetist prepared, then of course we need to prepare the rest of the team. And if you talk about from the preoperative phase, it's important to explain to the surgeon and to the team that because the patient's awake, there may be some movement that occurs because they need to get comfortable or in response to some discomfort, so they need to be aware of that. I also make sure I explain that block insertion for awake breast surgery needs to be followed by a cooking time or a soak time, so the impact of what we've done is able to reach maximum effect. We don't want to take our patients into surgery and allow the surgeon to start before the block is maximally effective. And sadly, this takes time, and sometimes this impacts the efficiency of a list. But if you've decided to do awake breast surgery, it's important that your colleagues understand that. And then I do make sure that we have all of the equipment available for positioning. It may be we need extra pillows, it may be that we need to use a ramp to sit the patient up, and certainly I've now started putting both arms out, and I'll explain a bit more about that later. We then need to remind our colleagues that they mustn't be leaning on the patient during surgery. They shouldn't do this even with surgery under general anaesthesia, but it's even more relevant when the patient's awake, because the patient will feel that discomfort or that pressure in the non-anaesthetised area. And likewise, with regards to resting instruments in kidney dishes or kidney bowls on the patient during surgery, we need to remind our surgeons and our scrub team that they mustn't do that. I think it's really important, of course, that you then discuss with your surgeon where the incision is going to be, so you make sure that the technique that you're using will cover the skin for the incision. And sometimes if it's not fully covered, then it might be that you do some infiltration in the area. And also let our team know if the block is not maximally effective, what our plans are for rescue. If you then look at the intraoperative phase, it's really important that we maintain patient dignity as much as possible. When the patient enters the OR or the operating theatre, before exposing the patient to palpate the breast or to examine them, we let them know, we ask them for permission to do that, and we make sure that we use clear patient communication the whole way through. Really importantly, if the patient experiences discomfort or pain, it's important that we let the team know and let them know that we're going to do that. We'll ask them to stop so we can establish where that discomfort is coming from. Sometimes that pain or discomfort can come from areas other than the operative site. It might be that you've got a blood pressure cuff running on the same arm that you have a propofol infusion running, and that can cause discomfort. It may be that somebody's leaning on a part of their body that they don't realise, or it could be that the calf compression devices that we use to reduce the risk of venous thromboembolism, maybe they're causing some discomfort. So it's important that we ask everyone to stop, establish what's going on, and then we've identified what the issue is, that we employ some sort of strategy to deal with that, and that may be rescue local anaesthetic, it may be increasing the sedation, or it may be using dilute amounts of opioid or non-opioid analgesia to help them get through that. And the whole way through the procedure, we need to make sure we have easy access to the airway and oxygen and or sedation, and also the monitors that we'll be using to monitor the depth of sedation if possible. And then the final phase relates to the post-operative phase. It's really important at that stage that you stop the sedation at the earliest opportunity. You can see in the picture in the background here, towards the end of the operation here, this particular patient, we stopped the sedation. They were really thirsty. We managed to give them some water, and also the patient can assist with moving their body so the surgeon can apply the dressings optimally. And as soon as you can, as I said, it's important to get oral hydration in there and get the patient up and about, mobilising as soon as possible. I'm now going to talk about some of the tips and tricks and things to think about when you're performing this technique from some of the mistakes I may have made in the past, and so you can optimise your technique. The first thing to think about is to pick your block strategy. We clearly understand the nerves, the dermatomes, and the areas of reduced sensation that you can get when performing certain blocks. So with that knowledge in mind, think about where the incision is going to be and what anatomy is going to be disrupted during that surgery. And it may be that you can modify the blocks that you use as a result. There is a difference between the amount of tissue that's disrupted between a lumpectomy or a quadrantectomy versus a mastectomy, so that should be borne in mind. And of course, if they're doing axillary node dissection or axillary node clearance, that can sometimes be a really tough area to anaesthetize. So is axillary surgery taking place? If so, you need to make sure you cover that. With that in mind, the next question to answer is, which team are you on? What do I mean by that? Well, people generally tend to fall into either the paravertebral team or the fascial plane team. Now, if you're performing a paravertebral, I've moved from a single level paravertebral to multi-level paravertebrals. Some people have described the technique using the intertransverse process block or even the ESP block, but in my hands, a paravertebral at multi-level is really effective. If you're on team fascial plane, you would consider an anterolateral plus or minus an anteromedial incision. The type of blocks you might use are serratus plane or pectus serratus, plus or minus that interpectoral plane block. And if there's certainly going to be a medial incision or medial nociceptive impulses, you might consider doing a parasternal intercostal plane block. There have been occasions in the past, and it's not unusual for me to cite a multi-level paravertebral, and if I have some local anesthetic volume left or dose left, I might dilute that up so I can reinforce that with either interpectoral, pectus serratus, and or a parasternal intercostal plane block. The next point I want to discuss is block success. It's really important that you don't accept suboptimal or limited spread. Watch the dynamics of the blocks that you're citing as you do them in real time. If you're not getting multi-level spread, consider doing an extra level injection. Don't administer all of your volume at one level and then realize actually it hasn't spread very well, or it's just an intercostal block, because it's really difficult to convert a suboptimal block into a successful one for surgery. Make sure you test your blocks thoroughly, and if you have deficiency in a certain area, don't just think you can cover over the cracks with or paper over the cracks with heavy sedation. Do something about it. So it's really important that you do test the blocks, whether you use ethyl chloride, pinprick, or even tissue forceps to pinch the skin. Whatever it is, make sure you test it thoroughly and act accordingly. Then I said I was going to talk about sedation, so it's really important you personalize sedation to the patient, and I think sticking to the mantra or the principle that less is more or less is more effective is certainly the right thing to do. Be careful when you're using opioids. I've had issues in the past when I've used opioids and been a little bit overzealous with my administration, so certainly only use opioids if you need to, and if you do need to use them in dilute amounts. So that brings me nicely onto this sort of spectrum of sedation diagram I've got here. There have been some cases where I've managed with no sedation at all, just talking to the patient or even just playing music in the background. Other situations when I've used very small doses of midazolam, I have used ketamine in doses of 5 milligrams as rescue analgesia, and dilute amounts of fentanyl or alfentanil at points when things have been a little bit more uncomfortable. And I'm not a stranger to using a low dose propofol infusion, but I think it's really important that you don't allow yourself to go into that general anesthesia without airway, that Gower area. Another agent that I haven't used, but I've heard people talk positively about, is dexmedetomidine, and that's something that if you have at your hands at your disposal, you may want to consider using. Next, I want to talk about positioning. And positioning is really important. You've got to make sure you have all the supports, the padding and the pillows there, the common areas where people feel uncomfortable, the back of their knees. And as I said, now I start to put, even if the operation is just on the right arm and the right axilla, I'll put the left arm out as well. And that's because if you have the arm by the side and unsecured and have the patient sedated without realizing it, sometimes they can move their arm and it will interfere with the operative site. So if we put both arms out onto arm boards and gently secure them and tell the patients that you're going to do that, sort of like a crucifix position, they're then prepared and you can act on a patient moving their arm before it happens. Be aware if the patient's unable to lie flat, you will need to adjust the bend of the table to have them sitting slightly head up, and my surgeons now become comfortable operating on patients who may not be completely supine. So again, that's a key part to having that pre-operative discussion. I also want to talk about oxygenation here, and as I said, sometimes you might find that your patients are well and their indication for awake surgery means it is unrelated to respiratory or cardiorespiratory disease, so you can manage without. You might just have nasal speculums, or you may just have a simple face mask with some way of monitoring carbon dioxide, so you can assess respiratory rate. But the thing that I moved on to using a lot recently is high frequency nasal oxygenation. So you can deliver oxygen at high flows, humidified, and if there are some areas where you need to slightly increase the sedation for a while, this can get you out of a lot of trouble. So certainly this is something I've used a lot in the past. The next thing, or the final thing I really want to talk about, is when you should stop and when you should reconsider what's happening. If you put the block in and when you test it, it's inadequate, that is a time to think, stop, I need to reevaluate. Especially if you've used the total amount of local anaesthetic you're allowed to for that surgeon, for that surgery, not for the surgeon, and if you've had sufficient cooking time. If you've got a block that's inadequate, it really makes sense to stop and say, right, you know what, we're going to reschedule for another day, because I can't stress enough, unless your plan B or backup plan is to give a general anaesthetic, if you haven't got an effective block, it's going to be very difficult to get that patient through just using sedation. The last part of the presentation, I want to talk about and highlight some of the publications that are out there. I'm not going to talk in detail about them, but certainly I'm going to give a QR code to link you to those particular papers. So, just using paravertebral alone, there have been papers dating back to 1999 where single level paravertebrals are being performed, and certainly as we've come into 2024 and 2021, people have started using ultrasound guided thoracic paravertebrals to assist patients through awake breast surgery. So those references are there. What about paravertebral plus something else? Well, again, these papers have existed. We've got our paper there in the middle from 2018 where we use a single level paravertebral block plus a PEX block, as it was described then, so interpectoral and pectoris serratus, to get a group of about 16 or so patients through surgery. Within that small case series, we did have some patients who required conversion to general anaesthetic, and again, part of what I've learned from that process was we didn't let long enough pass for patients to test the blocks, or maybe some of the blocks had suboptimal spread and we didn't act upon them. So I'm trying all the time to learn from previous experiences. There have been case reports here where people have used single fascial plane blocks for awake breast surgery, and certainly there's been a report from the ESP, Ioana Costache, who described the MTP block, which has now been renamed the intertransverse process plane block. She described cases where she used an MTP block for surgical anaesthesia, and people have used serratus anterior plane block as well. And then I think quite excitingly, there's people using a combination of fascial plane blocks. There are a couple of papers here. I just want to point out the top one here where Brian O'Donnell and his group use a really quite a sensible approach here. They performed an interpectoral plane block, and then through that same needle insertion point, they drove the needle down to the pectoris serratus plane and really took out the whole anterolateral aspect of the wall and did a inject local anaesthetic and chase the volume as you went down, and then they performed a parasternal intercostal plane block to get a really nice antramedial and anterolateral coverage of the chest wall. And within that paper, there are actually some supplementary videos so you can see that process taking place. So I want to finish off by saying that awake breast surgery is a journey, and certainly I've started off with much more heavily, deeply sedated patients using propofol and opioid, and made my way down, adjusted my technique from a single shot paravertebral to now multi-level paravertebral. It's a journey. You've got to find your way, and there's no doubt that success starts with taking that first step. So in conclusion, awake breast surgery is possible with a prepared patient, a prepared team, and a prepared anaesthetist. Make sure you have a backup plan or that plan B, and in my opinion, a paravertebral block is really king and key here to achieving successful outcomes. I do have to say a massive thank you to all of my surgeons who have allowed me to learn this technique and perfect the technique on our patients, and to all of our patients who have agreed to go through it and trusted me and helped me hold their hand through the technique. Thank you very much for listening, and I hope you enjoy the presentation.